Good afternoon, good evening, good morning, whatever time it is in your part of the world. A very warm welcome to Amsterdam in the Netherlands. Now, my name is John Clare. I'm a medical journalist from London, and it's a real pleasure for me to be here today hosting this event. Now, I've been here today with a group of real international experts who have taken part in quite a rare event. It's been a real multidisciplinary discussion about anemia management. Now, I say multidisciplinary because we have hematologists, oncologists, nephrologists, anesthesiologists, blood management experts, and a whole host of other people. Now, what we've been doing is talking about the best way of managing anemia in patients. The experts have come from all over the world, from Europe, US, and also from Australia, and I'll introduce you to some of them in a moment. Now, the discussions we've had have really focused on the best way of managing anemia, either with blood transfusions or with the erythropoietin-stimulating agents known as the ESAs. Now, the discussions have been thought-provoking, very lively, and to be honest, some of the things that we found out today have been quite surprising. One of the things we discovered, for example, was that the recent evidence about the potential risk of blood transfusions is not well known and not really well understood. One of the experts said in one of the sessions today, he said some people regard blood transfusions as like a placebo that's doing no harm. Now, he said that's not right. A blood transfusion has a risk, and that risk must be taken into account when we're thinking about patient management. Another expert from another country said, I think in my country people think that blood transfusions are like the weather. There's no point complaining about it. You may not like it, but there's nothing you can do. And that's not right either. Also, an expert from the UK, who we'll hear from later, he said it would be interesting to imagine that the ESAs have been around for 60 years, and we suddenly came along and said, we've discovered this new thing called blood for transfusion. If we applied for a license today for blood, would it have the right safety and efficacy data to get through the approval process? So, very stimulating kind of stuff. Now, we've also had wide-ranging discussions about the different needs of different types of patients, about the need for education for clinicians and for health authorities. We've also heard about the cost of blood. A lot of people think it's free, but it's not. About the falling supply of blood and the rising demand for it. And we've also heard how the age of the blood that's used in a transfusion can have quite a dramatic effect on the outcome for that particular patient. So lots and lots of lively discussion. Now, our aim today is to bring you on this internet broadcast a flavour of those discussions with the distinguished panel of experts who've been with us. Now, I'll introduce them in just a moment, but before I do that, can I please have the first slide, which I need to draw your attention to, and it says that this meeting is organised and supported by Janssen Pharmaceutical Companies of Johnson & Johnson in EMEA, that the views expressed in these slides are those of the individual faculty members and do not necessarily reflect the views of Janssen or Johnson & Johnson. And the presentations may include discussion of off-label use of drugs. Now, the format, if we can have the next slide, please, for how this will work today, is we will have a number of quite short presentations from members of the scientific committee, but most of it will be panel discussion. And then we aim to finish by 5:30 this afternoon. So, without further ado, I would like to introduce our first speaker, who is Axel Hoffman from the Curtin University in Western Australia, and the Centre for Population Health Research. So, Axel, over to you.
Hello, everybody. My topic is not seen here. Here are my disclosures of conflicts of interest. And I want to start right away with variability of transfusion across Europe. You can see Denmark, for instance, transfuses 65 units per 1,000 population compared to Romania with about 15 per 1,000. So there's a range in the ratio of 1 to 4 in transfusion utilization. But even more on a hospital basis. We looked into elective surgery in 16 public hospitals, for instance, in Austria, for METCH patients in orthopedic hip surgery. And you can see that for the same operation, depending on the hospital where you finally undergo the procedure, the likelihood ranges between 15% to 84% for the same intervention. And if you would say, let's assume that the first 5 are representing an acceptable transfusion rate, and you do the median of those as a benchmark, then you can clearly see there's a potential for reduction. But the question is, how could it be reduced, the transfusion utilization? Well, by applying 3 pillars. The first pillar is an optimization of hemopoiesis. The second one is the minimization of blood loss and bleeding, pre, intra, and post-op. And the third one is harnessing and optimizing the physiological tolerance of anemia. And this, of course, must be a multidisciplinary team approach. Now, what are the drivers to move one from a product-focused transfusion to patient blood management? I want to run quickly through 5 of these drivers. The first one is a supply issue. What you see here, and this is representative for many developed economies and countries, you can see that the 20 years increase of population or the population growth of the old age segment is about 75%, compared to the segment of the neonates up to 40 years, which is only about 15%. So in other words, on the supply side, there are more and more who need a transfusion, depending on less and less donating the blood necessary for these transfusions. So we have a supply problem. But the much bigger problem is the demand problem. This age segment, neonates to 40, they need just about 10 or 11 units per 1,000 population per year. This segment needs about 35. But the old age segment, which is exploding as a socioeconomic strata, uses 180 per 1,000 population. So you can see there is clearly a leveraged demand for blood products in the future with a shrinking supply. The next one is the cost of transfusion. Here is, for instance, a study showing the product cost in 4 institutions and ranging between $260 and $170 per unit, but getting the unit into the veins of the patient with all the testing and the actual administration, the nursing time, and aftercare or post-transfusion care shows us that what we call activity-based costing costs between $1,180 to about $500, depending whether it's in the US or Europe. And if you now multiply this cost per unit transfused with a transfusion rate for surgical patients, then you end up between $3,500 and about $2,100 per patient. The next aspect is risk or safety. We all agree that HIV, Hep C, and hepatitis B is not a problem anymore, although it's safety at very high cost, by the way. But what about the newly emerging infectious agents? There's potential for severe clinical outcomes according to the CDC, and there is support that there's other pathogens which might support elevation to a higher priority in the future, like chikungunya right now in Australia, moved on to this higher level. There is other groups, they carry public and/or regulatory concern already, and there is another large group of pathogens which is on the radar. The next problem is transfusion and outcome. And we have, as a group of experts, identified more than 500 papers published in the last 15 years looking at transfusion and outcome. And the large majority of these papers show that transfusion is always or almost always associated with adverse outcome. And there are also some randomized controlled trials in some very specific patient settings. This paper recently published looking at 38.6 million patients in the United States, basically all Medicare records from 2004, 5.8% of these, or 2.3 million of these patients, have been transfused. And after adjusting for age, gender, comorbidities, admission type, or DRG, transfusion was associated with a 70% increase of mortality, a 90% increase of infection rate. The length of stay was about 2.5 days longer, and the charges per patient about $17,194 higher. How much of this is causal, we still don't know, but we have a lot of indicators that there might be or should be a causal link. And this adds up to $40.1 billion in more charges. Finally, does transfusion really work the way everybody thinks it does? Well, this picture speaks for itself. It shows that hemoglobin doesn't equal hemoglobin if the blood is fresh or it's stored up to 42 days. There are a lot of changes, rheological, morphological changes, biochemical changes, biological changes, and others. And there is clearly evidence, experimental evidence, animal models, and other data showing that this has an impact on a patient. So therefore, the World Health Organization in this spring agreed, the 63rd World Health Assembly adopted by resolution that patient blood management must be on the agenda of countries, of nations or states, not only developed but also developing countries. Thank you very much.
Thank you, Axel. Excellent, great start. Can I ask the panel to come up to the stage now, please, because we are going to focus really on the discussions after that very good start. So we have joining us Mario Di Carto, Herr Gascon, Paul Cornes, Donat Spahn, Arya Sander, and Gert Meyer. Okay, welcome to all of you. Okay, let me start, if I may, with how do you balance the safety of blood transfusions? Maybe start with Mario Di Carto. How do you balance the safety of blood transfusions versus patient-driven outcomes? How safe are blood transfusions, first of all?
Well, from what we heard during this meeting, you can divide it up in two areas. One is the product itself, and second is the outcome in the patient later on. So what is being checked very regularly, and I think very in a good fashion, is the product as such. The short-time side effects are usually registered and so on, but as far as late complications, there's not very much going on there. We need a lot of data that is not available as of now.
And what about in the US? What happens there? How safe are blood transfusions regarded?
Well, again, I think that it's the same applies in the US, that we have to look at the safety of the product versus patient outcome. And we know that infectious complications or transmission of infection, especially envelope virus, is now a statistical threat, really not a clinical threat anymore. But we know that the other, which is the non-infectious risk of transfusion, is one which is what we're grappling with and have a difficult time putting arms around it in terms of the clinical implications. One of them being immune modulation, because again, transfusions are an active tissue, and the recipient may end up with immune modulation, which may now affect their clinical outcome. And that's the area I think that we're really trying to get our arms around. So one is the risk of the product is clearly minimized by being as safe as possible. Mm-hmm. But we've all heard the term that the safest unit of blood is the one that doesn't get transfused. And then you have the other, which is patient outcome, which is we could see over the time there's more and more data point to the fact that there's an association with worse outcome, which is dose dependent when it comes to transfusion.
Paul Connors from the UK, can I come to you? Because you were the person who earlier said if we'd invented blood today for transfusions, I'm not sure it would get through the safety and efficacy controls, approval process. What do you mean by that?
When we develop a new agent, we go through a series of steps of safety, evaluation in patients, randomized trials against best practice. And I think because this is a product we've had for 100 years, transfusion, used in mass markets after the wars, lots of people who were injured, we never went through that. And we're using blood in ways now that wasn't envisaged. It was originally designed to support people who were hemostatically in real trouble. And I know in cancer patients, that's my specialty, that even when your hemoglobin's above 11, 1 in 3 of my colleagues will be giving a transfusion, presumably to increase quality of life. And yet, despite all our searching, we've only ever found one paper that suggested you could improve the quality of life of anemic patients when you transfuse them. So that to me says there's a huge knowledge gap. And once you start totaling up the potential costs of this, $40 billion in the US, similar amount in Europe, that's a huge unmet need and a reason for studies. And just thinking about blood as a drug suddenly brings to mind all the steps we do for a novel agent, how we use it, how we get peer review, how we get consensus about its use. Let's just do the same for blood.
Per Gascoigne, can I ask you, because we've had a lot of data presented today talking about the potential risks of blood transfusion, the potential downside, but that message hasn't got across. Is that because this is very recent data? People don't understand it, don't want to hear it? What is it?
I think that it's a lack of information, a lack of education. This was a common theme in the big discussions. For instance, in oncology, all the data on the alarm signal, which is a real alarm signal transfusions, has been in the journals of intensive care, infectious disease, cardiac units, not in oncology. So obviously when we give a talk to our colleagues in oncology, they're surprised that we come with such incredible amount of data with clear alarm signals, and they are not aware of that. So they don't understand that. So I think a major, I would say, a bullet that we get from this discussion is information and education to all our colleagues to understand that it's a serious matter, there's alarm signals in transfusions, but we're not aware.
Okay, let's turn to the patient outcomes, and perhaps I can come to Donat first, perhaps. What are you aiming to do with a transfusion? Are you aiming to improve their quality of life, overall survival, get the hemoglobin to the right level? What's your aim?
Well, in the perioperative period, usually blood transfusions are given in order to improve oxygen delivery to the tissues, to improve oxygenation and function of the tissues. Now, if we look at the existing literature, we find that exactly this aim is not being met by transfusion, in that ischemic complications like myocardial infarction, stroke, and kidney injury are significantly increased in surgical patients who receive a blood transfusion. Therefore, the traditional view of how to use blood transfusion even perioperatively is not founded on any sound principles. So it's just history and behavior.
Gert, what's your view?
Well, I think the nephrology community is a little bit more advanced because we are more dealing with patients with chronic anemia. We are still aware of the times when ASAs were not available, when the patients actually were transfusion dependent. So the danger of continuous use of blood transfusions in these patients are still in the mind of the nephrologists, and they relate to iron overload, and they are also relating to allosensitization, which has a negative impact on transplantation. So I think in the chronic anemia setting, the nephrology community is still aware of these problems. We have the aim to stay away from the critical hemoglobin levels that we used to accept in these patients. In these patients, the administration of blood actually led to an improvement of the quality of life. But this was a very low quality of life that was maintained. So we can do much better now. In the chronic kidney disease patient, not on dialysis, I think the situation is a little bit different. And I think here we have to find a policy how to use this product.
Okay, I want to come back to dialysis patients in a few minutes, actually. What's your aim with the blood transfusion?
Well, I think we need to step back, because I think that Mr. Hoffman presented the variability of transfusion across the nations in Europe, showing you again that there's very little science here. And I think we need to understand that blood is not bad. It's the act of transfusion which may get patients into trouble. And the issue is that the aim is not to confer risk. So we need to identify, and that's what Dr. Spahn was talking about, is the fact that we need to identify which patient population would benefit from a transfusion. Because in the absence of any benefit, all we are offering the patient is at risk at that point. So being a resuscitative agent, making a very difficult clinical decision, transfusion, it shouldn't be sort of a trigger, if you will, is the aim, if you will, in terms of transfusion medicine. So it still remains one of the most difficult clinical decisions to be made, and I think that, again, we need to at least show that we're not going to give harm to the patient, that we can demonstrate some benefit through the transfusion. And as already mentioned, it is becoming more and more difficult to demonstrate benefit, both in terms of studies on patient population outcome, as well as looking at the physiology of stored cells.
Axel Hoffman, can I ask you, because one of the things that's becoming apparent is that it's very important to differentiate between different types of patients, of course. So it's not just a transfusion. You might have chronic kidney disease patients, as you mentioned, or people recovering from total hip replacement or whatever. How do you do that, and how does the patient's condition affect your decision?
Well, the gross distinction is, of course, medical patients and surgical patients. Mm-hmm. But we can see that a lot of these principles, the patient blood management principles, apply to both groups to some degree.
Mm-hmm. Can I move on to the age of the blood? Perhaps, Axel, stay with you for a moment, because you just presented a very dramatic picture there of the blood from 0 to, how many days was it? I can't remember now.
Up to 42 days.
42 days, okay. Do people know that?
I'm sure that the majority doesn't know that. They just think blood and the hemoglobin equals hemoglobin. But what we know is that in vitro there are dramatic changes over 42 days, and some of these changes occur already after 2 or 3 hours after donation. I
mean, before you tell us that, what's the impact of those changes? That photographically, microscopically, they look very different. What would you get from 42-day-old blood that you wouldn't get from 1-day-old blood, or vice versa?
Well, of course, we need more studies about this. But what we know is, for instance, we have vesiculation, and vesiculation, these little particles might be one of the contributors to thrombotic events. We know that there is impaired perfusion and reduced functional capillary density, which might be part of the explanation why the oxygen uptake is not the one we want to see after transfusion. There might be microchimerism involved. There is, because of the loss of nitric oxide, vasoconstrictive consequences. So there's a host of unintended consequences for which we have at least enough animal data, enough experimental data, and they are concurrent to some degree with the overall outcomes data. For instance, there was a study conducted in the United Kingdom by Gavin Murphy, published in Circulation. They looked into a cohort of 8,500 cardiothoracic or cardiac surgery patients, and they saw that the transfused patients, after looking into the confounders, that the number of ischemic events went up after transfusion rather than going down. But you would assume that the transfusion improves oxygenation and would not result in ischemic events. So the opposite is the case.
Okay, we've got some questions in from the live broadcast. Thank you for the questions. Let me start with the first one to you, Axel. At what HB level, what hemoglobin level should we transfuse the patient?
Well, I'm probably the wrong person to ask that, but again, I want to refer to the comments that it's more the question of the symptoms and not of a numeric trigger. Okay. And the other point is we shouldn't start the discussion at the trigger point. We look at these 3 pillars and we can say that a transfusion is a missed opportunity. When we focus on optimizing the patient's hematopoiesis, in other words, we fill the tank before he undergoes or she undergoes an intervention by stimulating the own blood system, and then we do all precaution to keep as much in the tank as possible, in other words, minimize the bleeding and blood loss, transfusion becomes obsolete in most of the cases, in elective surgery at least. And so the third pillar, harnessing and optimizing tolerance of anemia, is really the last resort. And the very last resort then is a transfusion.
Okay, can I move on? Paul, can I come to you, talk about the socio-economic impact and the cost of blood transfusions? I think we said earlier, some people think blood costs nothing because it's donated free.
It's true. We know most people are paying somewhere around 80, 120 euros for a unit of blood, and typically will transfuse 2 or 3 at a setting. But once you just start looking at reimbursement that health authorities will pay, we are using a day hospital bed. We know that when people have hemoglobins down around 7 to 8 typical transfusion triggers, that they're often not self-caring, they need transport to hospital. And some of the studies that we've done suggest that you're paying over 1,000 euros for that unit of blood. And it doesn't stop there, because of course it's all been donated by someone and they've given up time. And we always think, what else could you do with that money? We joked about where people are getting transfusions. Very few people get a bed, they're sitting in chairs. It takes a big resource from the hospital that we could perhaps use in better ways. And so certainly in a cancer hospital, when we're transfusing people with hemoglobins of 11, and we're told by our colleagues in critical care that tissue perfusion perhaps is going to be fine at around 7 to 8, offers a huge opportunity for us to invest the money we're spending on that treatment, at least some of it, in researching the best way to use it. So I'm going to go back and argue to our Medical Research Council, I hope, that we should get some more trials underway.
Good. Do you think that there's enough health economic data out there for people to make that case, or will you be taken seriously if you go back to your hospital and say, look, this is actually costing a lot of money?
Well, I think that the awareness is very low on this, and this is probably one of the facts that we should keep working on, to keep up the awareness, or to create the awareness that this is a very costly procedure, and not just looking at the unit cost, because there are a lot of costs around in collecting the blood and providing the blood. And this is still true in the situation that we don't know what we are really doing with it, if this is benefit or harm. So I completely agree with most of the panel that probably any other medical intervention would not pass any legislation to get approval if it would go the way we are using now the infusions.
Are you? In the US?
You know, we've had, for the last 2 decades, we've had a few publications looking at the variability of transfusion. And just one that was just published last month looking at cardiac surgery in the United States, a very robust study of over 100,000 patients and in more than 750 hospitals. And the variability, just taking red cells, of transfusion was anywhere from 8 down to under 10% to over 90%. So there's a huge opportunity here where there's no difference in outcome to reduce the amount of transfusion, which again are enormous cost. I mean, we already discussed the issue of cost, and I think that Mr. Hoffman presented some of that. But if you could see that you could reduce this utilization of resource and use those funds in other areas that we want to develop, the opportunity is there. So I think that we have plenty of data right now suggesting that our benchmarking, if you will, in terms of transfusion can always be lower than what it is right now, saving an enormous amount of resource.
Is it a question really of changing the mindset of the doctors, in the sense that physicians and surgeons as well are always aware of the cost of drugs? Perhaps they need to be also aware of the cost of blood. Would that be fair?
Yes, I think that's just one element. I think that there is an umbrella of education needs to be done. And we already have data on that showing that, again, the more education you receive about transfusion, the less you use.
So obviously, every time you remove white blood cells is an important thing. And the second, irradiation, obviously, you can destroy some of the particles, etc. Especially, that's is almost a mass for, always has been a mass for bone marrow transplantation. So this is an improvement. Obviously, increases the price of the whole thing, but it's a cost of the safety of the blood product.
Okay.
I'd pick that up. We know from our studies of transfusions in colorectal cancer that the earlier era transfusion studies showed a worse outcome, but in the modern era, where we now use leukodepleted blood, that difference appears to have fallen back, suggesting that this immunogenicity theory has some backing behind it.
Okay. Donat, do you have a comment?
Well, yeah, I mean, the leukodepletion has been introduced in certain countries as a default measure, and the effect in terms of outcome in the surgical arena was not universally better at all. I mean, there are dozens of studies that specifically looked at that, and what they found was that, you know, some febrile reactions were probably a little less in patients receiving glucose-reduced blood, but many or most of the major outcomes that we discussed before, namely mortality, major infection, lung injury, kidney injury, and all that did not change due to glucose reduction. So in certain little aspects, minor aspects, that might be beneficial, but in terms of major outcomes, there is not really a clear picture.
Gert, from the nephrology point of view, is that the same?
Well, I would disagree from the nephrology point of view, clearly, because I think even though the data have been produced about 10 to 15 years ago, that it has been shown in the patients that are on the transplant waiting list that non-leukocyte depleted red blood cell transfusion leads to allosensitization. This is creating a patient population that not only is difficult to handle after transplant, but that also has a prolonged waiting period to transplant. Both factors, I think, are associated at least with a deleterious outcome after transplantation. So I think in the nephrology community, the use of leukocyte-depleted blood transfusions has become a common practice.
Okay. Finally, a view from the US?
Well, not really a view from the U.S. Let's put things in perspective, and that is that the data is not definitive one way or the other in leukodepletion. And remember, it's a leukoreduction, really. It's not a leukodepletion. The normal unit of red cells contained is about 10 to the 9 white cells, and we reduce it to 10 to the 5. So there's still plenty of white cells left. The other issue is that we think of red cells as being completely inert and having no immune activity, and I think that that's something that we're now looking more. We need more data, but we're looking at that. So I don't think that the answer may be that leukodepletion is a better unit than a non-leukodepleted unit, but again, we're very focused on the product and not on the patient. The other issue is radiation, which shortens the life of the unit of red cells considerably, down to 24 hours. So again, if it's going to be used after radiation, it has to be done very, very quickly.
Okay, I know somebody wants to come in here, but there's a question from the audience over there. If we can give that person a microphone, please. Can you tell us who you are, first of all?
Ian McDougall from London in the UK. I was just going to pick up on Gert Meyer's comment about leukoreduction in the nephrology setting. In fact, I've had occasion to look at this recently, and it is incredibly conflicting. There is indeed a study, I think one of the strongest studies published in the Journal of American Society of Nephrology by Karpinski et al., showing absolutely no effect of leukoreduction on allosensitization in the nephrology setting. So I think there are data for and against a benefit for leukoreduction in the nephrology setting in terms of HLA sensitization.
Okay, thank you. One other question from the internet, if I may, from India. Aimed at Axel Hoffman, but that's probably because you were making the presentation when people were sending their questions in. So, now, in my country, the blood transfusion cost is lower than the ESA, in India this is, and being an oncologist, I find it difficult to keep patients waiting for hemoglobin to rise, then administer chemo. Axel, it says. Axel, what is your take on that? Do you think we should not go for ESA?
Well, at least we should see what is the effectiveness of transfusion. We all perceive that transfusion, again, does the job everybody wants. Of course, you have a high hemoglobin level after you're transfused, but and you have corrected the lab value, right? But did you really fix the problem of the patient? And especially, what about the mid and long-term outcome of that patient? And this is, I think, the rather bigger question.
Okay. Right, well, thank you very much. That's a great start to the panel discussions. I'd like you to ask you to thank the panel, and then we'll move on. Thank you.